assessment, or when you see it livid or sort of bluish, or if you have noticed notice his feet cold, you may suspect your baby has a heart disease. The idea is to have a consultation, to have a clinical history, to have a physical assessment, to have the oximetry and then chest X-rays to see the size of the heart and see how much blood is going to the lung. So with these four things, you can have an initial approach to heart diseases. There are other tests such as the EKG or an echocardiogram, which can define in a more accurate manner what is the cardiopathy. Um, Blood test or more specialized exams such as echocardiography or MRI. So the idea in the physical exam, the doctor asks you questions when you get to the ER. So the question is, since when? Since when your kid presents this? Does he perspirate when eating, or does he get tired when eating, or when he is breastfeeding? How many times does he have to stop, or when he drinks from the bottle, right? Because children do not rest while eating; they just eat, right? Does he get bluish or violet? Does he gain weight? Those are the kind of questions physicians ask. Another thing to consider are the background, whether the mom had a pathology during pregnancy, if there was a viral infection, or if the mother presented diabetes or pneumonias, or if there are any family history of heart diseases. You may think that the kid or the baby has a heart disease. And finally, the physical assessment. You have in a global area, you have an inspection, palpation, and auscultation, vital signs, pressures on the top part of the body, on the hands, and compare it to the pressure on the legs, taking the saturation on the upper part and on the lower part. Listen for murmurs, touching the kid, whether he's cold or not, to see whether the upper part of the chest is going rapidly. So these things may indicate the patient has a cardiopathy, and you can diagnose what is the problem. Maybe the kid has a a heart deficit, maybe fatigue, or maybe the kid has a low systemic output with shock. Perhaps he's cold, he cannot breathe, he, he looks poorly perfused, he's in a very poor condition. This kid needs a ventilation, or when the kid is bluish. So these three clinical stories require urgency and attention in a priority manner. So how do we start? The physical assessment and the clinical history. You take an oximetry to see whether the kid has a good saturation, and with chest X-rays, you can see flow in the lung on where there is little of flow to the lung. So you can have an initial approach, which is the one we have here. Congenital heart diseases work on two ventricles, and there are other heart diseases where only one ventricle, they present in only one ventricle. So in with two ventricles, we have pink or purple. So non-cyanosis, they can have high or increased flow or normal anterograde flow to the lung, which is the amount of blood that the heart expels to the lung. Is it normal or is it increased? Or we can have cyanotic patients with cyanotic with increased blood flow to the lung or decreased blood blood flow. So we can have an initial diagnosis approach with these pathologies like this. The QPQS is a concept which we will see in all the presentations. QP refers to all the blood that goes to the lung, and QS is the blood that goes to all the body. The heart is a pump that expels the same amount of blood for the lungs and the body. So if the right side of the heart and the left side of the heart have any defect on the wall between those two sides, then there will be blood from the left side that will go to the right side, that will deviate to the right side. So there will be more blood towards the lung and less blood to the body. There will be pink blood that will contaminate the right. So the patient becomes more pinkish, because if you take the oximetry on a hand or in a finger, but the blood to the lung will be increased. On the other hand, the lung may be decreased to the blood to the lung, because it may be obstructed, so that's contaminated, dirty or blue blood towards the body. That makes the patient to be cyanotic with a decreased flow to the lung. The idea for us is to balance the QPQS, the amount of blood that goes to the body, with the amount of blood that goes to the lung. This is an example of a normal heart over here. So in the next case, we will see some patients, and we will see some, or each one of the pathologies. This girl has breath distress at rest. There is a nasogastric tube. He cannot pee. She gets too tired and she doesn't gain weight. She is 7 months old, but she looks just a newborn. She's tachycardic. She has a normal saturation, it's pink, and she has chest X-rays with a lot of flow to the lung. So these patients that look pinkish with increased blood flow to the lung may have disease, including defects on the wall that divides the right side from the left side of the heart. So they may have defects between the two atria, or defects between the two ventricles, or defects between the two large arteries. So in all of these cases, we will have pink blood to the pulmonary vascular bed with increase of pulmonary blood flow. So in the patients, we have an irritable, anxious patient, cold, there is not sufficient blood to the brain to be at ease. He doesn't know whether he needs to go to the toilet. So this kid has low systemic output. The amount of blood to the body and the brain is not sufficient. The heart is too large. There is an obstruction on the passage of blood from the heart to the main artery, which is the aorta. There are smaller children that may have a similar course, where you see saturations above or superior to the ones on the lower portion of the body. The same goes with the pressure. These are children that coarctated the obstructive left side pathologies, everything that avoids the blood coming out the left ventricle to the aorta towards the body. So all of this may cause obstructive pathologies on the left side, and they will create shock syndromes or low systemic output. Case 3 is a desaturated kid, is cyanotic saturation in 87. Normal saturation is above 92%. So this kid saturates on 87. A large liver, cannot breathe on his own. He has difficulty in breathing. So you see the X-rays, we have a very large heart with increased pulmonary flow. So all diseases in the heart that generate circulatory mix that makes the pink blood to mix with the blue blood in the right side. In this case, we have an arterious truncus when there is a single vessel, and it mixes the blood from one side and the other and causes cyanosis. As I was explaining before, the lung pressure is 1/3 of the pressure of the aorta. So the blood will predominate, will want to go towards the lung, because the pressure on the lung is lower. That's why instead of despite having a lot of flow to the lung, the child looks cyanotic. Another pathology is the connection, total abnormal venous pulmonary connection, where the pulmonary veins that should arrive to the left side, instead of getting to the left side, they return to the right side. So they mix the blood that comes oxygenated from the lung with the blood that is blue over here. So this mix makes the patient to turn purple. Another kind of disease is when the arteries are transposed. That is to say, the pulmonary that should leave from the right side leaves from the left side, and the aorta that goes from the left goes on the right. So the circulation is transposed. So if this patient does not have any defects between the septum that divides the heart from the right and the left side, he will die, because it needs that blue blood goes to the lung to oxygenate, and that pink blood is able to get to the aorta. So if there is no mixing at any time, the patient dies. And finally, the fourth case is the purple child, saturates at 73%, but she's happy because the amount of blood that goes to the lung is little, but the amount of blood to the body is sufficient. So this child saturates the same. Let's remember that what saturates in this test is hemoglobin. So this child is more anemic than this other. That's why she looks more purple than this one. So this is the typical example of this sort of pathology, obstructive pathologies on the right side, where the blood cannot go out towards the lung. So this tube, which is the pulmonary vein artery, is obstructed. So blue blood deviates towards the aorta through this defect on the septum that separates both ventricles. So there is blue blood coming to the aorta. This is a tetralogy of a lot, where the right ventricle has an increased size and the flow to the lung is decreased. Sorry. So to wrap up this idea, heart diseases that work with two ventricles are divided into non-cyanizing pathologies, which are pathologies with effects on the septum, dividing the left from the right side, with short circuits from left to right. Pink with normal pulmonary flow, that is to say, there is an obstruction from the left side outlet to the rest of the body, and pathologies which are cyanotic with high pulmonary flow, which include circulatory flow with short circuit right to left or obstructive on the right side. Well, short circuit from left to right. So let's remember that these diseases that make the patient or the baby to see cyanotic, we may have two ventricles or a single ventricle. In pathologies with a single ventricle, necessarily the child will be purple because the blood will mix. And depending on how the blood vessels are organized, those who leave the heart to the body and the lung will have a flow to the lung or normal or decreased pulmonary flow. So we may have a single ventricle which is on the left or with the right morphology, or may have an aspect of both cases, which is what we call undetermined. And the key is how the blood exits to the lung. If it goes through both vessels, the blood will go to the lung and there will be a lot of flow to the lung, or there will be a heart failure and a hyperflow to the lung, or the outlet to the body will be obstructed, so all of the blood will go to the lung, and we require a tube or a connection between the two arteries so that this provides blood to the aorta and the body is not without blood. So the child will have a low systemic output or shock, or there will be an obstruction towards the lung. And again, we need to have this ductus arteriosus to communicate both arteries to pass blood from the pulmonary to the aorta. In that case, we will have low pulmonary flow. So how and when, if the child is pinkish and has a heart murmur and the child looks good, is warm and gains weight, since the child has a murmur, it requires an assessment by a heart specialist. If he has a murmur but doesn't gain a lot of weight and is well, but the consultation must be priority. But if there is a murmur, it's pinkish, but there is a delta of pressure or low saturation or difficulty in breathing, that child requires urgent attention. And the same goes with the pathologies of the heart diseases with cyanotic babies. If the baby is cyanotic and has a murmur, but is warm and gains weight, it's an ambulatory consultation. If he is warm and gains weight poorly and has a murmur, there is a priority consultation. But if the saturation is below 70 and he has a hypoxia crisis, loses consciousness, that baby requires an urgent assessment, or that kid, so that he achieves survival. What does it mean that the pathology is complex? Simple pathologies have a single defect and we can correct in a single intervention, whereas complex pathologies have larger morbid mortality. We may have more diseases. We'll have several defects. There is not only one defect on the wall or on the septum separating the ventricles, but there is also another obstruction in any of the two larger vessels. So they require surgery to correct it, or they are not susceptible to correct it because they may have a single ventricle. So I may need to, they may require a palliative surgery instead of a corrective surgery. Dr. Jennifer Hard will talk about the difference in a moment. So this is the intention of our presentation today. That was the approach. So thank you very much for your attention. These are children with complex pathologies that have achieved their survival. Thank you very much. Well, thank you very much, Claudia, for your presentation. It's a very educational presentation. Now we have the lecture or the presentation by Dr. Diana Patricia Fajardo Jaramillo. She will talk about heart surgery in children, from correction to palliation. Diana is from Bogotá, is a surgeon and physician from Universidad del Bosque. When completing her training, she was trained as a general surgeon in the military university in Bogotá. She did a subspecialty in cardiovascular surgery in Universidad Javeriana and a fellow in cardiothoracic surgery in the in London. She was under the mentorship of Dr. Victor Saab and Dr. Martin Stolpe. So Diana and Dr. Sara Mendoza are the core of the heart surgery program, and they are the ones who take these complicated patients to surgery. Diana, good afternoon, and thank you for joining us. Good afternoon. Thank you very much for the invitation. Okay. Diana, habla. Escuchamos. No. Well, just a moment. She's sharing the screen. We need a moment. There we go. I want to tell you now how we treat congenital heart, how to treat congenital heart diseases in children. All pictures have been authorized by the kids' parents. I want to show you a cartoon. Sorry, we are not sharing we are not seeing your presentation, doctor. Okay. Okay, now, yeah, she's sharing the screen. Okay. Okay. No. We are having some issues with the presentation. Oh, okay. Here we have the screen. Okay. Well, as I was mentioning at the beginning, okay, sorry about the technical difficulties. We apologize for that. Well, now I want to tell you how we treat congenital heart diseases in children with surgery. All pictures of patients have been used with the authorization of their parents. And as I mentioned before, I want to start by changing the vision that people have with surgery. In this cartoon, where we have the picture of a physician vanquishing death with a scalpel, but it's not just the work of a person, but if it's a team. So we believe surgery is a choice of life for the child and his family. And this life choice is the result of a work with parents. It is important that parents realize that something is not okay with their kids. Fortunately, The parents are aware now about the prenatal diagnosis, and either with the gynecologist, the general physician, or the pediatrician, refer them to the vascular center where the kid is assessed, and after the assessment with different specialties, we can offer the patient surgery. So within or out the OR, what we want or what we do works as a symphony, as an orchestra, where everyone plays a little bit of the music, and we want all the symphony to sound well and the music to sound beautifully. And to do that is the patient to do well with our treatment. And who are the ones who perform the surgery? It's a group of people that includes the, the, the group of people that attends the patient before the surgery. They require intensive care, sometimes pediatric, cardiology, the diagnosis imaging group, pediatric hemodynamics, general physicians, electrophysiology, and the group within surgery, which includes anesthesiology, perfusionist, instrument specialists, and nurses, heart surgeons, particularly trained in pediatric surgery, and the group that manages the patient after surgery, which includes all of us. So during the heart surgery, what we do is to correct an anatomical defect that the patient has, or we fix it in a way that the patient has a better quality of life during his lifetime. When we can correct the defect, for instance, to close a hole in the heart and have the heart work as usual, we call that corrective surgery. But when the patient has one or more defects, when it is not possible to have an anatomical correction so that the heart is operating as usual, but the heart is operating in a different manner, what we do is to have the patient having less symptoms and have the best quality of life possible. We call it palliative surgery. Sometimes we do palliative surgery while the patient is bigger or older, so we can have later on a correction. We specifically about each type, we have the different surgeries, as Claudia mentioned before, how the heart works better when we fix and the heart operates as it should. How should it work? On the left side of the heart, through these tubes, we have all of the dirty blood from the body. On the upper tube, which is the upper vena cava, we have the dirty blood, and in the lower cava vein, we have dirty blood from the lower limbs. So from there, the blood goes to the pulmonary artery and goes to the lungs, where blood is clean, and then oxygenated blood goes to the left side of the heart, comes through a sort of gate in the middle, and is pumped through a large tube to the rest of the body through this artery we call the aorta. When there are defects in and out the heart that we can operate so that the heart functions like that, it's a corrective surgery. And one example, and it's the more simple example, is a hole in the heart, and we close it. And here I want to introduce you to Antonella. It's a 2.5-year-old girl, and we close this hole in her heart with a little patch from her own tissue. Here we have another example. Here's Juan Martin. Juan Martin is a 3-year-old kid with a little bit more complex defect, where one of the main tubes in the heart were not leaving from the proper side, but the tube that was supposed to come from the right side came from the left side. That is to say, the pulmonary artery came from the left ventricle, and the aorta, which should come from the left side, was coming from the right ventricle. So what do we do in surgery? We place each tube on the proper side, and even we involve the small arteries that take blood to the heart. So speaking about palliative surgeries, which is when we cannot have the heart working in its regular manner, the most typical example are patients with single ventricle physiology. What it means is that the child is born literally with half a heart, maybe half a heart on the right side, or half a heart on the left side, or half a heart undetermined. So in order for this child to live and to have the best quality of life, unfortunately, we still don't know how to rebuild or how to regrow this half a heart. So what we do is we create several strategies during different surgeries to make the heart work, and that's what we do with the with hypoplastic left heart. So what we do is the dirty blood does not come to the heart but directly to the lungs. So we see how the superior vena cava goes directly to the lungs, and the lower inferior vena cava goes directly to the pulmonary artery, and the right side becomes the left side, sending clean blood to the rest of the body, so to say. There are other kinds of palliative surgeries when we have different cardiopathies or different diseases. When there is too much flow to the lungs, what we do is we have a little band or belt that regulates the flow. And sometimes when we have a lot of holes in the heart and the baby is very little to be operated, we do this palliative surgery. We wait for a time, months or even years, and then we can have the corrective surgery. This is another example. When the kid has very little flow to the lungs, we can have a small tube so we can have blood through an alternate way to the lungs. This is called a shunt, a systemic pulmonary shunt. In this kids where the heart works differently, we require an adequate mix of blood in the heart. So instead of closing holes, what we do with the surgery or catheterism is to open holes so there is a better mix in the heart. So we see some examples of palliative surgeries. This is the first stage of hypoplastic left heart syndrome. As we can see, all of the left side has not been developed, including the main artery, which is the aorta. So what we do is that the artery, which is actually developed, which is the pulmonary artery, we use it to reconstruct the very little one, the aorta, and we separate it from the artery, from the lungs, and then we place a tube to regulate how much blood goes to the lung. This is called a healthy NORWOOD surgery, and this is a picture of the surgery. This tube corresponds to where blood comes to the lungs, and this is the reconstruction of the aorta. When we see single ventricle physiology, or they live with half a heart, the formula for them to live, to be able to live, which we know nowadays to have a better quality of life, is to have several stages or several surgeries. The first one is the one I just mentioned, which is the NORWOOD surgery, which is done during the first days of life. The second stage is done when children are about 6 months of age, and it's called the Glenn surgery. What we do is we connect the vein that has the dirty blood from the upper part of the body, and we connect it to the pulmonary artery. And now when the kid walks and is between 3 or 4 years of age, we have a third surgery, which is called a fontan, where we connect the inferior vena cava, bringing dirty blood from the lower portion of the body to the pulmonary artery. And here we see some of our kids in this in our Promesa program, where we have in different stages in palliative surgeries. We have Luciana with a VT shunting, Francisco has a bending on the pulmonary artery and a septostomy. This is Lucas, who is in Glenn stage, and Dana Valentina. And we made a third Fontan surgery. So the message is, in children with different physiologies, for instance, hypoplastic left ventricle, we have Tiago's model. It is possible to live with half a heart, and here we have all of our Tiago's family. So with regards to the approaches, I want to tell you about how we do the surgery. What is the approach? The approach is how we get to the children's heart, and we can do it in different manners. One is to have an incision in the middle of the chest, where we open the sternum, and that's called an approach through sternotomy. We can do it on the side through the ribs, that's a thoracotomy. And nowadays there are certain surgeries that we can do on the side with a much smaller surgery incision, so 4 or 5 centimeters below the axillary area, and that's a minimally invasive. He has a small scar below his armpit. And here we have some pictures of these sort of approaches. We have the sternotomy going in the middle of the chest, and here we have a child prepared to have a small incision below his armpit. So what can we do through the thoracotomy? We can close abnormal conduits, for instance, ductus arteriosus. We can fix the large vessel when it has a specific narrowing, which is the coarctation of the aorta. We can place tubes that are needed, such as the VT shunting, or we can have simple intra-heart surgery when we can have a CIA. When we have complex surgeries, on the other hand, where we need to reconstruct inside the heart, we always have a sternotomy, so we go in through the middle of the chest. What else do we use in surgery? So first of all, the human resources that we have initially, and with regards to the physical materials, we use a lot the tissues from the kids themselves. The heart comes a little bag protecting it. We use this bag, the pericardium, to have small patches, and we close holes, or we can have reconstructions in and out the heart. We also use these tubes, which are made of a special plastic material, where we can have connections in and out of the heart. And as I explained before, there are some sort of gates in the heart. We call them valves. Sometimes we fix them, and when we cannot fix them, we replace them. We have some biological tissue valves or mechanical valves, and we tend to use pieces of heart from a donor, and those are called holografts. That's something that we use a lot, which is a machine. It's the ECMO machine, the extracorporeal machine. So many of the surgeries, or most of the surgeries, are reconstructions and fixes within the heart. So to do it, we need to stop the heart and to have something else doing its functions. That something is this machine. What this machine does is, through some hoses, it collects the dirty blood coming from the body to the heart with a hose on the upper portion of the superior vena cava, and then there is another hose on the lower vena cava. It goes through a pipe, or what we call a circuit, to a reservoir, which is a container where we have the dirty blood. And from there, it goes through some pumps that send the blood through an oxygenator, which oxygenates blood, as the name says. And through the hoses, we send the blood to the main artery, already oxygenated. So here we have some examples. These are the little tube with which we connect the machine to the aorta, the main artery in the body. And these are the tubes that take the dirty blood from the body to connect it to the machine. And here I am presenting the extra corporeal circulating machine. So 80% of the surgeries we do, we use this machine, and by using it, we can close holes within the heart. We can fix obstructions on the right side or on the left side of the heart. Surgeries such as the ones we mentioned, as transposition of the great vessels or hypoplastic left heart syndrome. Without the machine, we can have more simple surgeries such as a ligation of ductus or a coarctation of the aorta. Another resource we have in our institution is the ECMO machine, that can have the function of the heart and the lungs, not only for some hours, but we can use it for several days. We can use it when the strength of the heart is too weak, or for some children that come very ill and we need the machine before the surgery. So coming back to the scheme that Claudia mentioned about congenital heart diseases, we can see it as children that are pink or blue children or cyanotic children, and they have a pulmonary flow with normal, high or low flow. So following this scheme, let me tell you some of the things we can do in surgery for this sort of pathologies. So for pink children with high pulmonary flow, we can have holes. When we have holes in the heart, we can close them with patches of tissue, or when we have abnormal connections out of the heart, such as ductus arteriosus, we can close them with suture. When the child is pinkish and the pulmonary flow is normal, for instance, when the main tube is narrow, that's called a coarctation, and we remove the narrow part and we reconstruct the artery with surgery. Or when some of the valves are diseased, we can fix the valve. We can have a valvuloplasty, or we can replace it either with biological tissue or with mechanical tissue. For those cyanotic or blue children with high pulmonary flow, For instance, children with great transposition of the gray arteries, what we do is to replace the tube located on the proper side. Or when we, instead of having two tubes but have on a single tube, we have the two tubes coming out of the corresponding side. So for cyanotic children with low pulmonary flow, for example, those kids with tetralogy of Fallot, which is a very common disease for us, when children have a hole in the heart, but besides the outlet of the right heart is obstructed, so we close the hole in surgery, and with the patch we increase the outlet. Or children with Epstein's anomaly, when the gate in the middle of the right side, instead of being in the middle, is in the lower portion and doesn't operate properly, we reconstruct it and we place it where it should be. Some children, after the 3 stages or due to the disease they have, they ultimately require a heart transplant. And what we do in our institution, we have performed 50 heart transplants. And here we have some of our children with heart disease, one of them already operated. So as a conclusion, what we can do as surgical group, multidiscipline team, depends a lot on the conditions in which the patient arrives. For us, it's very important that the patient comes in the best condition. That's why we think this Promesa program that takes care of children before the surgery and between the surgeries, and they will come in the better condition to the next stage of surgery. So thank you very much for your attention. Holy wow. Thanks to Dr. Diana Fajardo for her presentation about heart surgery. We will continue with our program today. I want to introduce now Dr. Sorry. Oh, we want to introduce now Dr. Chitra Ravishankar, graduated in Mumbai, India. She had a fellowship in the Children's Clinic and Pediatric Cardiology in the Mount Sinai Hospital in New York. And she currently has her clinical practice in the Schiller Hospital in Philadelphia with heart failure and heart transplant. And she's part of the heart monitoring group in patients. So, Dr. Chitra, we welcome you. Le damos la bienvenida a la doctora Chitra. Es un placer para nosotros contar con usted hoy. Doctora Chitra. Bueno, buenas tardes. Sí, la podemos escuchar. Sí, correcto. ¿Pueden ver mis diapositivas? No aún. Un momento, por favor, ya vamos a compartir la pantalla. Creo que aquí va. Un momento. ¿Podemos ver la diapositiva? No aún. No la presentación. No están viendo mi presentación. No aún. Oh, ok. Disculpen, vamos a intentar de nuevo. Creo que ya está empezando a llegar, sí. Ya, yes. Bien, ¿la pueden ver ahora? Perfecto. Bien, mis disculpas por esto. Bueno, de nuevo, para todos, buenas tardes. Y muchísimas gracias al doctor Javier Castro y a los organizadores por invitarme a presentar esta charla sobre el periodo interetapas. Sí, simplemente solo tenemos video y audio. Iniciar video, pero no estoy segura de cómo, pero no me pueden ver aún, pero podemos ver la presentación, más no la imagen de la doctora. Hola, ¿me pueden escuchar? Sí, sí podemos escucharte, sí podemos escuchar y ver la presentación, el PowerPoint. Bueno, voy a continuar simplemente por respeto al tiempo. No, realmente no sé qué está ocurriendo, me disculpo. Ok, entonces, una vez más, de nuevo, mis agradecimientos. No tengo conflicto de intereses relacionado con esta charla. Estos son algunos de los puntos que quiero cubrir en los siguientes 15 minutos o algo así. Como sabemos, la tasa de mortalidad para la cirugía de defectos congénitos ha seguido cayendo y sigue siendo el síndrome de corazón izquierdo hipoplásico la más alta, en la que tiene mayor mortalidad, en la que puede llegar a casi el 20%. El mejoramiento en el manejo quirúrgico y postoperatorio ha llevado una mejor sobrevida para todos los procedimientos neonatales quirúrgicos, incluyendo la paliación para los defectos de ventrículo único. Sin embargo, el periodo interestadio entre el alta neonatal y el estadio 2 es algo vulnerable aún. Bueno, voy a iniciar con un caso, un bebé de 39 semanas con un diagnóstico de síndrome de corazón izquierdo hipoplásico, buena función en el eco, una aorta ascendente de 2.5 milímetros, el bebé estaba estable en prostaglandina y eventualmente se le hizo un NORWOOD con una derivación RBPA. El pecho fue reexplorado buscando inestabilidad e hipoxemia y se le sometió a cierre, tuvo cierre external tardío, cateterismo para hipoxemia persistente y se le colocó stents en estenosis arteriopulmonar y eventualmente se fue extubado. Se presentó taquicardia auricular y con un mes de edad el bebé pudo ir a casa predominantemente con alimentación con tubo nasogástrico. Este no es un curso atípico para un bebé promedio en riesgo o de riesgo promedio o de riesgo bajo en tener este síndrome de corazón izquierdo hipoplástico. Este es un dibujo, un esquema de la operación de NORWOOD estadio 1 y cómo se coloca la derivación en la izquierda. Y por supuesto hay bebés con atresia pulmonar que requieren un shunt BT modificado, como se le llamó inicialmente, al menos en los Estados Unidos y en muchos centros, y preferencialmente se utiliza stents PB en lugar de este shunt modificado. Otra opción para mantener en cuenta con la paliación son las bandas bilaterales y el stent, el APDA, es una opción interesante. Entonces, en el periodo interestadio es el periodo entre el alta del procedimiento de Norwood o de Shunt hacia a un estadio 2 o una conexión pulmonar superior. Y creo que estamos de acuerdo en que estos bebés claramente cumplen con la definición de frágil, que significa que se rompen fácilmente, que son frágiles. ¿Qué hace frágiles a estos infantes? Es la circulación dependiente del shunt, inherentemente es ineficiente, el, el suministro de ventrículo único hacia la sangre sistémica y pulmonar es muy baja y Hay factores contribuyentes que son la disfunción ventricular, la presencia de regurgitación de la válvula atrioventricular, lesiones residuales como la coartación, y también siempre se presenta el riesgo de trombos en la derivación, en el shunt, y puede llevar a esa shunt pulmonar. Algo que nos interesa en esto son los que pueden causar vulnerabilidades, enfermedades que pueden llevar a fiebre, a complicaciones por hipovolemia, hipoxemia, y todas estas enfermedades interconectadas pueden causar fluctuaciones en el sistema vascular. Desafortunadamente, estos niños van a tener un déficit de suministro por esas patologías. Las principales preocupaciones, o lo que nos preocupa, es el riesgo de fallecimiento interestadio, problemas de nutrición y de crecimiento, también la tasa de readmisiones, problemas de desarrollo, y también sobre los padres. De manera no sorprendente, los padres también van a estar muy estresados en estos interestados. Hemos discutido ya que hay riesgos de fallecimiento debido a esa inestabilidad de la circulación y esa susceptibilidad creciente a eventos inesperados como enfermedad respiratoria gastrointestinal o fiebre, que puede venir incluso de vacunaciones rutinarias, que puede producir descompensaciones en los bebés más frágiles. Entonces, para hablar un poco sobre nuestra experiencia en el hospital pediátrico, tenemos un programa de monitoreo. En los 80s y los 90s la tasa de mortalidad era casi del 14%, y no cambió mucho, realmente en la siguiente década hacia el 10%, y en la reconstrucción de ventrículo único la tasa de mortalidad era del 12%. Ahora, este fue un estudio, y fui afortunado de estar involucrado en alguna de estas investigaciones. Este estudio tuvo 549 pacientes de 15 centros en toda Norteamérica, que se les operó con un shunt modificado BT. De los 426 sujetos en interestadio, 88% sobrevivió al estadio 2, y el beneficio de sobrevida sobre este procedimiento de shunt, 6% a 18% para el grupo del BT modificado. En estos grupos, cuando hubo presentación moderada a severa de regurgitación atrioventricular. Otros factores de riesgos que se identificaron durante ese estudio fueron los factores demográficos, tales como la madurez, la etnicidad hispánica, el diagnóstico anatómico de atresia aórtica o atresia mitral. Entonces, parece que fue bien demostrado que los pacientes con el shunt RBPA contribuían a una mayor perfusión coronaria y sistémica, lo que daba estabilidad hemodinámica y daba, comparado con bebés de inestabilidad hemodinámica o con bebés que tenían dificultad de alimentarse. Esto nos lleva al siguiente problema en el periodo interestadio relacionado con nutrición y crecimiento. Todos los infantes que presentan cirugía cardíaca neonatal tienen riesgo de presentar alteraciones en el crecimiento durante el primer año de vida, y la mayoría están en riesgo de tener enfermedades de ventrículo único. Mencionábamos que en esos estudios, acá se hizo un estudio controlado con placebo, doble ciego, aleatorio, de inhibidor de ACE con enalapril. Se tomaron bebés aleatoriamente menores de 45 días de edad hasta los 14 meses de edad, se les hizo seguimiento, y el punto final primario era el peso con un puntaje Z a los 14 meses, y no hubo diferencia entre los grupos de enalapril y de placebo. Lo que nos trataba de mostrar esto con la trayectoria de crecimiento de los bebés en los primeros meses de vida. En el eje de las X vemos la edad media en meses y la tasa de sobrevida. En el eje Y podemos ver que el score era menos 1.2 al inicio, disminuyó hasta menos 1.6 al alta, pero no hubo un cambio muy marcado en los siguientes meses y gradualmente incrementó con ganancia de peso hacia el procedimiento de estadio 2. Entonces estos tenían un mayor impacto de lo que podíamos lograr en esta población de infantes. Entonces la etiología de la falla de crecimiento en esta enfermedad multifactorial es tener un equilibrio entre la alimentación, porque estos bebés tienen dificultad de alimentación debido por los tubos, hay lesión de cuerdas bucales, reflujo gastroesofágico, mala absorción de nutrientes, restricción de fluidos, y es una preocupación para los pediatras. Ahora, la restricción de fluidos y la mala absorción van a afectar a los bebés. De otro lado, tenemos un gasto de energía aumentado y todo eso puede ser excesivo en la carga hemodinámica y eso puede ser exacerbado por la enfermedad de ventrículo único. Ahora, hace unos años se realizó un estudio en el que 44% de los bebés se les dio alimentación oral exclusivamente, 33% requirieron la combinación de alimentación oral y nasogástrica, 13% exclusivamente alimentados a través de tubo y 10% exclusivamente a través de un tubo de tipo GJ. En cuanto a las readmisiones y cateterizaciones, al menos 50% de los pacientes son readmitidos. En nuestra propia experiencia, al menos 60% de estos bebés son readmitidos debido al periodo de interestadio. Al menos un cuarto presentó cateterización no planeada durante este periodo interestadio. Ahora, no es sorprendente que esto vaya a producir, o vamos a ver padres muy estresados, el temor de muerte, la alimentación, los problemas de crecimiento y de desarrollo, el estar alejado del centro quirúrgico, o el que se requieran citas frecuentes de consulta externa, la carga financiera, también el impacto sobre los hermanos del bebé, y hay impacto también sobre el matrimonio y la relación. Estos son puntos a considerar para estas familias. Hace unos años, Harman y otros hicieron un estudio en el que quisieron ver la percepción de los padres después del alta de la cirugía neonatal. Y de nuevo, no fue un hallazgo sorprendente encontrar que la mayoría de estos padres estaban notablemente estresados en cuanto a la alimentación y la ganancia de peso, particularmente en las madres, y las madres particularmente están deprivadas de sueño. Algunos comentarios de los padres pueden ver el vómito, parece causar mucho estrés, es constante, no hay pausa y no hay un momento para relajarse. Es también algo muy difícil y hoy es aún duro. Muy pocos podemos dejar a nuestro hijo. Yo estoy con mi hijo 24 horas al día, 7 días, y es un periodo muy estresante para mí. Entonces, ¿qué podemos hacer? ¿Cómo podemos apoyar a estos infantes frágiles y sus familias? Hace casi 2 décadas apareció el concepto de Ghanayem y su grupo en Wisconsin apoyando estos programas de monitorización en casa, en el que se tomó o se hizo un enfoque fuerte en cuanto a dar comunicación a los padres. Y esas fueron las claves: el fácil acceso de estos padres al proveedor de salud, y los centros también pudieron reducir la mortalidad casi a cero, y eso es algo notable de este estudio. Y posteriormente esto fue abordado por el establecimiento de la colaboración de calidad de vida pediátrica y cardiología. Se utilizaron 6 centros y se ha visto reducción de las tasas de mortalidad. La mayoría de los centros en los Estados Unidos ahora y centros en Norteamérica son parte de este grupo colaborador. De nuevo, las ventajas de tener el monitoreo en casa incluyen la capacidad de educar a las familias, de tener la participación, la detección de potenciales problemas, fácil acceso y de comunicación. Yo creo que esta es una de las claves, el fácil acceso que tienen los padres ahora a un equipo de cuidado en salud, a un equipo dedicado. Hay mejor coordinación entonces entre los prestadores de salud y esto resulta en una estandarización perdón, de la práctica, la reducción en la variación de los cuidados. Ahora, ¿estos programas han tenido algún impacto? Aquí tenemos datos de NPC-IQ y vemos el consolidado del equipo colaborador. Vemos que la mortalidad ha bajado de 9,5 a 5,1, entonces claramente han tenido un impacto. Ahora, ¿qué es protector? Algo muy interesante de los estudios en los que se utiliza la base de datos SBR, este fue un estudio retrospectivo de 330 infantes elegibles, 31% estaban dados al alta con digoxina. Ahora, muchos de estos pacientes tuvieron una incidencia de mortalidad de 12,3 y esto se muestra gráficamente en esta diapositiva en particular, y resultados similares se hallaron en el grupo de NPC-IQ. Esta es una cohorte más grande. Encontraron de nuevo un riesgo incrementado de mortalidad interestadio en los pacientes que no fueron dados de alta con digoxina. Es decir, esta medicación ha estado en el mercado por 100 años y es uno de los medicamentos más antiguos. ¿Quién diría que eso iba a ser protector para estos bebés? Ahora, ¿qué ocurre con los bebés? Con el impacto de las metas del monitoreo en casa? Es asegurar un crecimiento adecuado tras el alta, y esto se ha vuelto una alta prioridad para el NPC-QIC. Aquí tenemos un estudio que fue publicado hace unos años. Vemos en cada número individual se refiere a un sector, y en el eje de la Y vemos el cambio en el score Z, y vemos lo que podemos ver es que algunos de los centros a la derecha no les está yendo tan bien en términos de ganancia de peso en el periodo interestadio. Entonces, NPC-QIC propuso la implementación de este AS de nutrición. Es decir, con el monitoreo en casa se monitorea el peso con una báscula casera, se utilizan alertas rojas o banderas rojas para el monitoreo, y se tiene un contacto regular con las familias, se tiene la disponibilidad de responder preguntas sobre alimentación y nutrición durante el periodo interestadio, y se tiene una evaluación estandarizada de la capacidad de alimentación antes del alta. Ahora, el uso de esta red de aprendizaje de estos centros que no les iba tan bien antes de la implementación, según se demostró, ahora tienen una ganancia de peso más robusta en el periodo interestadio. Esto muestra la implementación de este grupo de colaboración, y esto va a mejorar los resultados para nuestros bebés. Ahora, esta es nuestra experiencia en el hospital. Hemos comparado nuestros programas de monitoreo en casa, incluso con estos bebés que son un poco más jóvenes. El peso era similar, pero la ganancia de peso fue mucho más fuerte en nuestro grupo de monitoreo en casa comparado con la cohorte anterior. En conclusión, entonces, los resultados han mejorado, pero estos binomios de padres infantes aún siguen siendo frágiles al momento del alta. La colaboración entre los centros ha facilitado el establecimiento de mejores prácticas para estos infantes frágiles, y yo creo que es justo decir que los programas de monitoreo en casa han tenido un impacto positivo en los resultados interestadio. Yo quiero terminar con esta cita. Dicen, me preocupa más que él se vuelva azul y morir. Entonces estaba revisándolo cada hora, y por eso es que los padres se estresan tanto. Antes de terminar, quiero reconocer a todos los miembros de nuestro programa de monitoreo de ventrículo único. Un agradecimiento especial a Alison Stack, es una enfermera dedicada al programa, y realmente ella es el corazón y el alma de este programa. Bueno, muchas gracias por su atención. Gracias a la doctora Chitra por esta excelente presentación y por compartir su experiencia. Well, continuing with our program, we'll talk about the PROMESA project. The presentation is called, Can This Be Done in Colombia? And so our presenter is Dr. Javier Mauricio Castro, who is the director of this program and has devoted all of his time and energy to the project. It's a pleasure for me to introduce him. He's a physician from Santander. He's a friend, a co-worker, a physician and surgeon from Universidad del Bosque, pediatrician from Universidad del Rosario, subspecialty in pediatric cardiosurgery. His main specialty now is in the clinician of heart failure and pediatric heart transplant in the foundation, and the attention of Cardiopaties in children, both in the ambulatory and hospital environments, and academic activities and research in the foundation. As I said before, he's the director of the project, of the PROMESA project. He directs this collaborative study with the research team of the foundation in cooperation with Pontificia Universidad Bolivariana and with the support of the Ministry of Science. Before Dr. Castro begins his presentation, let me remind you that there is simultaneous translation both on YouTube and on this WebEx network. Welcome, Dr. Castro. Thank you, Claudia, and thank you very much for being here. Let me allow me a moment to share my screen. See? Yes, you can see. Well, good afternoon, everyone. Let me tell you what is PROMESA. PROMESA comes from the need of what our patients need in a country like this, where there is a huge limitation of resources, when we need to use them in a more efficient manner to look after our patients in the best possible manner. Home monitoring. You saw the excellent presentation by Dr. Shitra. The question is, can this be done in Colombia? PROMESA means Home Monitoring and Health Education Program for Children with Complex Cardiopatias. This is a program that has been executed for 4 years, funded and supported by the Ministry of Science, jointly with Pontificia Universidad Bolivariana and Fundación Cardiovascular. This is a work that we have been doing in order to carry or to help our patients. All of the pictures were authorized by the parents or the caregivers. We have no conflict of interest, and this paper is presented under the authorization of the Ethics Committee of the Foundation, and this program is funded by resources of Ministry of Sciences. When we have children with heart pathologies that are not so complex, sometimes in newborn, the way these cardiopathies operate or work, they require a palliation or compensation, either surgically or with some sort of intervention to maintain the child alive and to keep on going to improve weight and to improve the conditions for a further surgery. On the left side, we have a picture or an image of the trology of Fallot. We place a tube here, a shunt. Here we have interventricular communication. It's a large hole that makes blood to flow preferentially to the lungs, and it requires this pulmonary banding. That's called a pulmonary artery banding, which limits the amount of blood to the lungs so that the lungs are not flooded. There are some pathologies that are more complex, and that's where home monitoring comes. Is the hypoplastic left heart syndrome. That's the largest cardiopathy because of their complexity. When these children are taken to surgery, the goal in newly born is to have sufficient blood to the lungs, not in excess, not in a scarce manner, so that they have the sufficient oxygenated blood, but also to ensure the body to receive sufficient oxygenated blood. There are two types of interventions. We have the NORWOOD surgery. In the middle, we have the NORWOOD shunting. The only thing we change is how we take the blood flow to the lungs. The other is called the healthy NORWOOD. And there is another procedure, which is the hybrid, which is a blend between the surgery and intervention, where we also achieve this goal. So in order to attend all of these children with complex heart diseases, particularly those with HLA, HS, we require a lot of human resources, technical resources, economic resources, emotional and social resources from the families, so that these children can survive these interventions. And even so, once they survive, they come to a stage called the interstage period. I call it the classic interstage period. But usually when we talk about interstage, we talk about the period when the child is discharged after this first surgery, goes home until the second stage or a second surgery. And it may range from 1 month of life to 6 or 9 months. Classically, it's called interstage when it refers to HLHS. When these children are discharged, they are usually considered stable, but we need to consider that they may have a sudden or even an unexpected deterioration that may cause this child to die. And even though the risk of dying is associated to anatomical factors, and despite the fact that these children may seem well and they may have some residual effects, these are very frail, vulnerable patients, as Dr. Chitra mentioned before. The factors we have reported classically in literature are anatomical defects. You can see on the right, you can see an echocardiogram. We see a heart dysfunction. We see a weakness on the heart muscle. You see this blue jet. This child has a low weight or conditions because of race and social condition. And when they don't get adequate weight gain, even if they seem stable and they leave the interstage, I recommend you to review the HLHS guidelines. This is a generalized problem. You can see a list of studies on the left side of the screen done on large North American centers and worldwide, where mortality of these patients it's very high. That's why the home monitoring programs have been developed. As you can see, this person walking on the wire, this is a balancing act that requires a lot of training, sacrifice, effort. But these children are very vulnerable and they may fall in deterioration. There is a high risk of mortality then. The response in the world, as Dr. Chitra mentioned, is the interstage home monitoring programs. These programs were developed initially thinking about hypoplastic left heart syndrome. But in this example from the publication from the Wisconsin hospital, you can see how before the monitoring program began, which are the blue bars, a significant percentage of these patients, even though they were apparently well, when they went to interstage of home, they died. Once the home monitoring programs were developed, and you can see how the reddish bars reach up to 100% almost. So the decrease in mortality with home monitoring program has improved. So worldwide, this has led to an initiative, which is the MPC QIC, which is the initiative to care for these patients, and that has been taken as a quality standard and in different countries in the world. So you see in the map, there is a large number of centers in North America and Europe that has this program in place to look after these patients, because this is an actual present issue. This is the overview in Colombia and Latin America. There was nothing so far. So when we reviewed our statistics of hypoplastic left heart syndrome in classic interstage, when these children were discharged, almost 42%, or almost half of these children died at home. And that began occurring after the 4th month of discharge, as seen in the picture. When we see the risk factors in our patients, There is a large majority of issues on the coarctation, the dysfunction of the ventricle, insufficiency. Some are significant, others not so much, but all of them contribute for these patients to have a greater mortality when they are discharged to home. And when we reviewed our cases, and we went beyond, we went to patients that received some sort of palliation without being HLHS. So out of 178 patients discharged, we have a large percentage, up to 37%, that are lost. 3% die, and we have a large 40% of patients lost once they leave the hospital after the first intervention. They don't come back to the second surgery. That gives a little bit more stability. So our challenge is not only HLHS, but also there is a large number of pathologies in Colombia, but because of our limitations, we need to care about them. That's why PROMESA, we adapt the definition of INTERSTAGE and we expand it to all of congenital heart diseases that require initial palliation on the neonates. So we are able to take him safely or more safely to a second surgery. And this is the population of PROMESA. What is the goal of PROMESA? We want to take our patients from this high wire, to a safer path, to a more relaxed road where we can walk safely, so we can take them to a second stage to have an intervention. So what is the methodology? It is based on 4 dimensions: the medical dimension, psychological, with our colleagues from Universidad Pontificia, the social dimension, and the technological dimension. So all of it is focused on the baby, on the patient. And we created this protective bubble by means of education, by means of a high degree of communication between the medical team, the patients, and the health system that look after these children. And that's why we use education and new information technologies. In the medical dimension, we focus on creating an educational program so that these children, before leaving, this is Carol Castillo, our nurse, she's in charge of providing a proper education so that their parents are aware of their diseases. Many of the cardiologists and surgeons meet the parents, and we help them, or we teach them to identify the disease, what is that diagnosis, and what is the next stage. And that's to do that, we created a lot of materials. We created some text. They are also, they can also be downloaded freely on our website. So there is a booklet for parents and caregivers, and another booklet for healthcare providers. So in these booklets, we develop the content so that parents learn how to look after their children, how to detect the warning signs, how to manage the medications, the technology tools that we are providing them. And even we have developed some educational processes. We have a channel on YouTube, we have videos. So when they want to reinforce all this knowledge, they are freely shared on YouTube. We have also an educational program on Udemy where we try to share knowledge to parents. So anyone interested, last year we developed a network of knowledge for medical staff, and we focus in sensitizing specialists and subspecialists and general practitioners and physicians in how to take care better of this family, not only the patient, but how to provide well-being for the patient and their families. In the technological dimension, we give all the parents a digital scale, a measuring cup for measuring the intake of milk, and a pulse oximeter. And with a smartphone, we provide them a data plan. So by means of an app, they can have measurements of saturation and heart rate on real time. Additionally, we developed an app, and you can download it from Google Play. It's only for the moment for for Android, sorry. In the future, we want to have it for iOS. But with this app, we send communications, educational material, and they transmit the medical data that we review over here This is the control center. This is where Carol and the cardiologist, we can, every time we have a dashboard or a control board where we have the data on real time, and the system has some parameters that generates alarms automatically when one of the preset parameters for each patient is in an abnormal range. We can consult the progression of oxygen saturation, weight, and how the patient is evolving over time. Particularly, this marks the future and the risk for these patients. In the technical dimension, we have the app, and we use information technologies a lot. We try to see with video calls, or we have weekly video calls, or even daily if necessary. We connect with these patients and we help them how to administer the medications. We can review any problems. And it's important because we are trying to avoid unnecessary out consults because of the pandemic, but we also want to detect problems and they consult on time so that they don't wait until the baby is in a severe condition. In the psychological dimension, the staff at the university, they try to be in contact with the parents through a specific chat. We try to maintain our parents committed. We share educations. We develop educational material that is Carter shared and is on the website as well. And we even have leisure activities. These are our kids in disguise for the last Halloween. And in the social dimension, which is very important for us in our context, and as a team, we try to support the parents to break these hurdles, these walls for healthcare access, which is sometimes created between the parents, the caregivers, the healthcare providers, and the physicians. We try to tear down this wall, and this, when people connect, they can get the medical monitoring on time, that they can access their medications on time with the proper doses, so that they can come to medical follow-up. We review their tests, and we find a connection so that these patients get medical attention in a timely manner. When we go over the cases, with the large majority of patients with pulmonary stenosis, patients with diverse single ventricle pathologies, CIV, and even some patients with HLHS. Initial palliations, this is the beginning of this bridge. This is the first time we have arteriosectomies and pulmonary artery, angioplasty with stents, hybrid NORWOOD, intervention procedures, or some combined procedures. The average age, the mean age is 19 days for first intervention, and out of these patients, we have been able to take this 11 patients through this bridge. 4 of them are currently in flight, 1 that requested to be removed from monitoring, and 1 patient that died interstage. So what I want to show you is, despite the follow-up, we have been able to reduce significantly these large numbers of patients lost in the prior experience, as I showed before. So at the end of the bridge, we have 5 patients on Glenn, 3 on definite correction, and 1 in shunting. In our case, the activities, we have about 1,200 calls. We have constant video calls, about 600 video calls, face-to-face clinical controls. Particularly with the pandemic, we are using more phone calls to have an adequate control, despite of the restriction and the containment measures to avoid contagions by coronavirus. And we have more than 2,000 alerts. And to provide education and feedback, we have even identified 15 critical alerts. In these cases, we have managed the patients to consult in a timely manner through the ER and to receive treatment in the ICU or even hemodynamic interventions. And we believe this has contributed to a timely management, preventing complications or even death. The Promesa project is a program adapted to the local needs and resources in Colombia for the patients that we need to look after more. It's a low-cost program based on a very robust educational component where we want to have a high degree of communication. We take advantage of current technologies to have virtual and face-to-face controls. And we want to improve the care of these patients and to make this fragile population to come successfully. This is the first patient that we managed to take successfully to a Glen, and now she's happy at home. And the main conclusion is that in Colombia, it is possible to have a heart monitoring program. It saves lives, it improves the outcomes, and it allows us to have a better precision of care. And we managed to have this high wire. We make it a bridge that allows these patients to walk with their parents to a second surgery. So thank you very much for connecting to us to this event, and I appreciate your time and your attention. Thank you. Thank you, Javier. Thank you for your presentation. Thank you for all of the effort you have given to this activity. Continuing our program, we have Dr. Claudia Patricia Bueno Castellanos, psychologist from Universidad Autónoma de Bucaramanga, Magister from Constance University and PhD from Constance University. She will talk about caring of carers. What are the psychological interventions to protect our carers? So Claudia, welcome. Okay, allow me a moment to share my screen. Good afternoon. Yes, we are hearing and we are seeing the screen. Yes, we cannot see your face, but yeah, I am turning on my camera. I don't know if you can see me. Okay. Well, good afternoon, everyone. It's a pleasure to be here with you, and thank you very much for the invitation. The university is very pleased to participate in this event. Sorry, we are having difficulties with the audio. I'm sorry. No, está entrecortado. Sí. Apparently, Claudia is having some. So if you deactivate the video, it's better. No. No. So we'll try to fix your audio issues. We, in the meantime, we will continue with Paula Fernanda Perez Viveros. She will talk about the care during the interstage period, how how to increase the affective bond and emotional development in children. Paula is a clinical psychologist, member of the clinical psychology group in Universidad Pontificia Bolivariana, researcher in mental health, psychology of health, and development. Paula has been with us during the process and the development of the Promesa project, and we want to welcome her so she can talk to us about her experience. So welcome, Paula. Yes, we hear you.
Te escucho perfecto. Debes prender tu video y compartir tu pantalla. Sí, ya prendí el video. Perfecto, ahí te ves muy bien.
Well, good afternoon, everyone. It's a pleasure for me to present the care during the interstage program, particularly what has to do with the affective bond and emotional development in our patients with congenital heart diseases. Many of the experiences that we have accompanied our carers. So I want to give a special shout out to all parents and caregivers seeing these presentations in this afternoon. So I would like to start by saying, no, we have a baby. When a baby comes to a family, it, it's a, it's an event that constitutes a stress factor, even though it may be a very exciting and highly emotional moment. But parents start thinking about everything that implies looking after this little baby, because we as a species we have a very long breathing term. So the arrival of this new being will will have an upset in their social and family life, even the task, the chores allocation, the responsibilities, and of course in the life project in each member of the family. So just by having or by expecting a baby, the couple will have an adjustment, a psychological adjustment, and that without considering that the baby may have a health issue. When the heart comes like this is a posterior view of the heart. There are, there are no inconveniences on the medical level. Everything goes well, the functions are okay. So this preparation for the birth, obviously there are some conditions during the gestational period that may have influence on this preparation that may increase the stress. So we have identified factors such as economic situation, the age of the parents, number of children, the age of the parents. So of course, whether the pregnancy was planned or undesired, or otherwise was it an accidental pregnancy. So some of these factors may cause these factors to be more stressful, or the situation become lighter on the other hand. However, in patients with complex congenital heart diseases, even though, the parents may find out soon that their child's heart does not look like this, but in their mental picture, the heart may look like this on the right. So what happens to this baby when he's born? What will happen during the first year of development? How will be their childhood, their adolescence? Will they be able to have a normal life? Will they be able to have a job, to study, to have normal, effective relationships? So the parents need to start working to change on their mental image. So this acceptance process takes some time, and with the diagnosis during pregnancy, the parents have the opportunity to get prepared, to get information about the heart disease, to get advice from a health practitioner, or to take actions or measures that will allow them to cope with the situation. In our program, we've had carers, mothers, and parents that were aware of their diagnosis, but we have also had caregivers that have found out about the diagnosis at the time of birth or even months after the birth of the baby. So, of course, this will make the adaptation and the acceptance of this blue heart to become much more demanding on the psychological level, because there will these coping resources will have to be used more rapidly on the parents and on the families to respond to the special needs of the babies. So we have to make more rapid decisions, and we may not have the complete information as if we had obtained a diagnosis previously. So in any of the two cases, either the parents know the diagnosis during the pregnancy, or if they get a late diagnosis, the role of the health professionals is very important. And in Fundación Cardiovascular, the experience has shows evidence of this kind, warm, human role that physicians in the foundation have at the time of telling the news or of giving the diagnosis, and when offering the possibilities of treatment. So parents and fathers and mothers, remember the encouragement words, the honesty in the management of our patient. They remember that from the professionals, from the healthcare professionals. And we have observed that increases the coping capabilities for the caregivers. So this is a very important indication, uh, as Dr. Diana Fajardo will present, for these patients, not only in our program, but in general in healthcare institutions that have the opportunity to provide this program. When a diagnosis is presented, so here we have a cardiologist here telling the parents the word cardiopathy. So your son or daughter has a cardiopathy. So automatically, a picture comes to the parents' mind. They see a mountain with a lot of obstacles. We have our children here. Many of these children are characterized by having a bluish color. They are climbing this steep mountain of several things they need to go through, derived from this, from their diagnosis and treatment, the relapses, medications, the surgical procedure, the therapies, and also the separation that children suffer from their parents due to their disease. Sometimes there will be a rupture or an interruption of the emotional bonding that normally they may enjoy, that and the parents also know about this, and they are concerned. How will I be with my son or my daughter, my baby, at this time when he must be in the ICU or he must be isolated or separated from me. So how will I accompany him? How will I provide? How will I meet that need for affection? That has been a very difficult experience, particularly during the pandemic, because the biosafety measures restricts more this contact, and we have to resort sometimes to information technologies so that through the voice they are able to communicate with their child. So all of this mountain of preoccupations. So once the cardiologist tells the news, so all this mountain comes to the minds of the parents, and something appears, which is anxiety, anguish, constant fear, concern for this little being that is uh, for whom I have a lot of feelings, but I also have responsibility that something wrong will happen. So of course, what parents will try to do is to take the heart with a ventricle that doesn't work very well, and as the song says, the song by Depeche Mode, to take this heart isolated from all the dangers in the world so that nothing happens to it. So that everything that the doctor has told me will not occur. So I can preserve my kid from anything wrong. So of course the patients know, the parents know, there's unimaginable situations that may occur. So of course the parents don't want their children to suffer. So we may have this anxiety transmitted to the child, and this concern and this preoccupation is also conveyed to the kids. This will not favor the process, but it will hinder the formation of this bond and also affect the emotional development. So despite of, or even though we want to take this little heart and isolate it and protect it, perhaps like in the picture, we want to do that. Once the child is born, or even before with the preparation for the family, the baby starts growing and developing, and the breathing process is not something, it's not a process where the child only learns, but the parents also learn. So for every child, there is a new learning process. In the case of parents with congenital heart disease, besides all this knowledge that they require, and as was mentioned in some previous presentations, they almost become honorary physicians because they are so informed about the procedures, about the consequences on the baby's health. And of course, they will be trained so that they are able to go hand in hand with the process of caring for the baby and the special needs derived from this cardiopathy. So breathing is like this picture. The father is on his mountain. This mountain is the mountain of life. He or she, the parent, has advanced well, and here we have a smaller mountain for, for our son or our daughter who's without supervised burden. What is the burden? And I drew it like the disease. It's a disease that will make heavier this road. But the parents would like to climb down and climb up this mountain with their babies on their backs. But they can't because they need to walk on their own path. They need to climb their own mountain. And the baby cannot come and climb the mountain for their parents. So parents climb their mountains and nobody, absolutely nobody, will climb it for them. So as children learn from their parents, I don't come down from my mountain to go and make it easier for my child. So I'm teaching that it's okay to abandon the mountain because he or she are not capable of climbing them. So instead of abandoning my own path and pretending that I can climb this road with my child, I can stay on my own path, remain on the life mountain, and, and see if it's possible for my child to overcome the obstacles. Why do parents, why can they do that? Because they can see the mountain from the distance and they can alert their children. They can plan so that difficulties uh, can be faced. And through this manner, we can transmit the awareness or the trust that this child requires for an emotional development. So Royce Granton says that in this world of extinction and catastrophe, a world where harmony and nature have been excluded for so long, is the world where he had to raise his girl. He cried two times, once in complete happiness and the second in anguish. What will happen in this world with all these difficulties that may occur during the birth or during the growth of my child? But we need to remember this, that babies, particularly in the first year, they are like little sponges, like little tape recorders. Everything they their parents tell or show to their babies, they will learn it. So, despite of all of this emotional burden of the mother, of the father, of a baby with a complex congenital heart disease, the learning, as we mentioned before, this own learning is perhaps the most important to ensure a positive bonding with the child. Of course, through this bond, we create a bridge where he or she can reach optimal development. So this infant, this baby is observing. That's that picture is the one the parents need to learn how to manage so that he can see that you can adapt to the chaos. So in this sense, what happens when parents are sad or anguished because the baby is ill? That's a reality. It's not that we try to conceal sadness or anguish. We try to make a, a, a process in the couple and a group because this is a multidiscipline diagnosis. So it's indispensable to have a mental health monitoring that allows this mother or this father to be able to manage those emotions, to manage that stress and anxiety coming from the diagnosis and the treatment, because we may have the mother or the parents to be continue depressed, so the baby starts perceiving that instability, that emotional instability, and of course he will be affected. Besides the difficulties derived from the medical intervention, this baby will not have an emotional support from his parents to be able to develop skills, the coping skills necessary so, so that he is an emotionally healthy person. So to conclude, I want to comment on what John Bowlby says. Life is organized better as a series of adventures from a safe foundation. What is the safe foundation? Is the bond between the mother and the father, or you see the father and the mother with the little baby here. So this bond is defined by Bowlby as this first relationship that a boy or a girl has with these first affective and socializing figures who are generally the parents. So the first human relationship that I have, and from that I will learn to defend myself from the world once I leave my crisis. So those are these first 2 years when we have this figure of the bond where it starts to form. This bond meets biological needs, psychological needs. So one is safety, feeding, the capability of having a mirror or a figure to model ourselves. That's why we see when children, when you see they see the camera, they start smiling, they start to imitate the gesture, they start to read emotions rapidly. So as they learn, they use them. So in this sense, many functions are served by this bond. In this sense, it's not to have a perfect recipe that allow the baby to acquire social skills, but to improve my mental health as a mother or father of a child with a congenital heart disease, to learn to manage my fear, my anxiety, anguish, depression, so that through this bond with the baby, he or she is able to develop the skills. So as human beings, a part of our brain, we have the capability to experience emotions. We have that kind of chip in our head. So what we need is a safe context from which I can go out in adventure. Thank you very much. Well, Paula, many thanks for your presentation. We'll continue our program or our schedule. We'll see if Claudia is now able to connect because she was having some connectivity issues. So Claudia will talk about the care for carers, psychological interventions that we need to have for those who are caring for our patients. Claudia Patricia Bueno is a psychologist from Universidad Autónoma de Bucaramanga, magister from Constance University and a PhD in Constance University. Claudia, you are welcome. You are. Okay. I'm having an issue with the audio. You are not hearing me with an echo, right? No, we hear you perfectly, Claudia. Go ahead, please. Okay, good afternoon. Please allow me a second, because I'm... Okay, I wanted to tell you what we are approaching in this presentation is the psychological care that can be offered to the carer of a patient with congenital heart disease. As Dr. Paula Perez said previously, having a complex congenital heart disease, which is a cardiovascular disease, can represent for the carer a stressful event, which is completely unexpected, that will overcome their capacity of reaction. This implies that the parent has to assume new roles, new life forms, new forms of life, and new ways of coping. It implies the carer to adopt a role to meet the demands uh, that the well-being of its child require, without necessarily having the experience or the prior experience to do it. In the carer, this implies a series of demands that are related to implicit elements in the psychology and at the individual level that we need to consider from the healthcare team and from the psychology team to be able to approach in a proper manner the carer, and also to increase in the carer the adherence to the treatment, which will ultimately give a better outcome for the child or the patient in this case. When a carer is exposed to a stressful situation, such as the one we are describing this afternoon, different elements appear or different challenges appear. They may be very exhausting for the patient. Similarly, the patient needs to be exposed to situations such as contextual variables which are related to demographic issues, income, resources, economical aspects, but also aspects, emotional aspects related to the disease, such as the severity, the duration, uh, evolution, the treatment, but also typical elements of the patient that belong to the psychological aspects of the individual, such as attitudes, behaviors, expectations. And finally, he also needs to develop a series of skills to be able to interact with the medical and healthcare team, the hospital team, who is providing this attention. Normally, towards this new and stressful situation, the carer does not necessarily have all of the resources to work properly with these kind of challenges that appear. So, assuming this new role requires the development of new strategies, new skills that may empower the personal development of the carer, but also the development of adherence to the treatment for the success of their child. So the typical situations to a stressful, vital situation where possibly the life of the child is at risk, uh, which is the case in our project or in the Promesa project, where we basically work with neonates for, and doing this, making this unexpected response and potentially stressful. The possible responses to this new situation are framed within three specific elements: physical responses, which are associated mostly to fatigue, headaches, sleep deprivation, uh, tiredness, muscle pain, loss of weight. On the psychological level, they may have sadness, anguish, anger, fear, catastrophic thoughts, and we have a response on the psychosocial and personal level, which is related in the negative case with the abandonment of day-to-day activities, neglect of healthy lifestyle habits, neglect of nutrition or leisure time, and neglect of self-care in general. That is why in this case it is very important to to, to make the focus of attention not only on the hospital level and on the level of the procedure that needs to be done on the baby, but also on the care of the caregivers. So when we are talking about complex congenital heart diseases or a disease, we need to talk the adherence to treatment. And adherence to treatment is this healthcare relationship that will establish or that will allow the child to receive and adapt and recognize this treatment as important for him. Obviously, if it is an older child, but if it is a neonate, the responsibility falls mostly on the carer. So given the factors identified in the health and disease process, both on the patient and the carers, it is necessary to approach a set of situations that increase the coping capability of the carer. These guidelines are addressed to the medical approach and the relationship that the carer may establish with the medical team, but also with him or herself, and also with all the fears, resistances, and all the psychological implications being faced towards this new situation. As Dr. Paulo Perez mentioned before, the anguish level towards the unknown, the generation of new strategies, or how to face developing new skills are very important elements that will define and foster, in the best of cases, the adherence to the treatment or the compliance of treatment. If the carer does not take into account these factors, or if they are not aware of these elements, there may be failures in the care of the child, and the treatment will not be provided in the best manner. So in this way, it is important to develop psychological models that take into consideration the carer, first of all. So internationally or worldwide, there are very few programs that talk about how we may have the structure of a program to work directly with the caregivers. So normally, the programs that are found have been developed in Europe or in North America, where the focus of attention is more devoted to work with the child and basically the procedure relationship with the medical personnel. So in this manner, it is important to devote time to develop a program that has more focus on the caregiver. We can find in the literature some aspects. There are not so many, but we can find some options or proposals that may provide insights on how to have this program addressed to this intervention. And this is what I want to show you now. We would have a proposal for psychological intervention that will have three elements, basically: the psychological assessment, psychological intervention, and psychological follow-up. So I will try to describe them basically what we could do, in each of the different steps. So the psychological assessment will be that first time of encounter with the caregiver, with the medical team, after receiving or after getting the bad news on the disease. And they will present with this first approach between the healthcare personnel and all the concept and changes on the psychological level that the carer is undergoing, and what will be that intervention level. The therapeutical goal in this first psychological assessment should be addressed at knowing the mental health state or the functional performance of the caregiver with regards to the performance context. In this case, we would have an assessment of the mindset. What is the impact of receiving the news? Dr. Perez said before, this is an ambivalent relationship because by being a parent, That's a relatively positive experience for most people. But I am receiving a bad news, which is my child is sick and the risk of death is very high. So we would have to begin a psychological assessment, a very deep assessment, to evaluate the most important elements of impact on the caregiver when facing this situation, this new experience. This phase requires clinical tools such as a semi-structured interview, application of some psychological tests, systemic observation. For instance, if we have the caregiver during hospitalization, we can have more contact with him or her. So it is important that this first encounter with the caregivers are in the best way possible, in the best quality possible, is to establish a therapeutic relationship that promotes trust and a status of well-being that we will offer to the caregiver, that he understands that we are supporting and that we are there for him or for her. And also to evaluate the emotional responses on the behavioral and cognitive physiological levels. What is the perception towards the expectations before meeting this diagnosis, and what are the current perceptions? How do they perceive this moment of life? We develop in this program a scale where we value the assessment. What is the perception of the disease? Am I perceiving it as something very severe, or am I perceiving it as something transient? So what meaning am I giving to this diagnosis? So precisely all of that is reassessed during that first assessment. We need to take into account the functional performance on the social context, on the family context. If the caregiver has a good support network, if he is on his own, what kind of social demographic variables are associated, what is his job situation, is he employed or not, what is the job burden. And also it's very important to review stressful events that they may have experienced in their lives and then may affect their reaction capacity. So stressful vital events may lead um, to worn out in our coping capabilities, and that needs to be taken into consideration in the assessment. So what are the coping strategies in this case? What's a carer that reacts in a more impulsive or meditative manner? Is there a network support, a support network for this approach? So during this first assessment is particularly important to identify how the patient is like, in this case, the caregiver, what is his present situation, and what is the status of acknowledgement of the disease, so we can proceed to the intervention or the follow-up phases. The second phase we propose is the intervention stage. This is where we start working in a more direct and deep manner with the caregiver based on the information given by the first assessment. So we already have some diagnosis information that will tell us, okay, what are the contextual variables, family, social of the caregiver, and what therapeutic adherence capacity they have towards or in view of the assessment we made. So at this time of psychological intervention, we identify two phases mainly. One, a psychoeducational phase where we provide more information, we educate, we are teaching, we are giving orientation to the caregivers in the approach. And we also have a clinical intervention phase, which would be related with deeper changes in thought structures and deep changes in mindsets or mind schemes. So the therapeutical goal in this intervention phase is basically to take care of the requirements of the caregiver and their families, which generate um, this stress. I need to start evaluating the negative impact of coping the disease, coping with the disease. This negative impact may be associated to stress burdens or to stress manifestations. And that's where we start doing a lot of education, informing the patient about the disease, about the evolution, about the coping capabilities. We try to activate support networks. We try to teach healthy lifestyles, habits for the caregivers. And we also may identify whether the caregiver has dysfunctional or irrational mindsets that would require a deeper clinical intervention. From the clinical intervention, we may have different attention modes. We may have current therapies, third generation therapies, for instance, mindfulness, acceptance and commitment therapies, cognitive therapy to work on these mind schemes. And we would have to design a roadmap that defines how we would work with the caregiver, considering what is the life purpose that they have in that moment, what are the meanings they are giving to that experience that may have a negative connotation, and approach all of these irrational schemes that they may have. So this would be sort of the work that we would have on the intervention phase in psychology within the PROMESA program. We are working with the caregivers in individual sessions. We're trying to identify these elements that I just mentioned. We have developed a scale, a psychometric scale, to assess the perceptions, the impact of the disease, support networks, interactions with the hospital team. So this will allow somehow to have a relatively more feasible assessment on how the caregiver feels or how they feel. Further, we would have a follow-up phase where we would go to review, or the idea is to review what we found in the first assessment phase, which dysfunctional schemes or irrational ideas were there, what was the impact like, what was coping with the disease, coping with the times at the hospital, sorry, and how they were changed during the intervention. It is important to consider here that the goal of this follow-up phase is to value both the clinical and therapeutic breakthroughs by the patient and their families after an intervention process, or after an assistential process or a surgical process. When we are talking more about the operation or any kind of medical procedure, it is important to take into account that we will have a follow-up on how the caregiver is approaching these sort of procedures or situations at that time. We will be focused on the management of mental health, functional performance, and how the acceptance is being developed and the specific care for the kid. The tools that can be worked on here and can be also on the clinical aspect, structured interviews, psychological tests, and systemic observation. We also consider the changes on the behavioral level, mind, on the perceptions, whether they have changed or not, whether the anxiety symptoms have decreased or the depression symptoms, whether those beliefs that were developed at the time of hearing the news have been strengthened or decreased or modified. So the follow-up phase is very important in all aspects, not only from the psychological standpoint, but from the social standpoint, because that gives a light, sheds a light on how the carer is being developed on his new role and the approach to the disease. So what is new in this that I am presenting to you? What we are trying to construct in the PROMESA program from Fundación Cardiovascular and Universidad Pontificia Bolivariana, we are trying to construct a program that is comprehensive and that considers not only the psychological process and the approach the caregiver has, but in this case, we are oriented not only to the medical management of the kids with the stress response that the kid may have towards the approach or the disposition of the medical team, because they may develop some phobias or anxiety disorders, particularly in children. So we try to see in a more comprehensive manner the caregiver as that potential support for the diagnosis and treatment of the procedure with the patient. So this proposal states a review, mostly literature review, in a systematic manner that allowed us to know what was being done on the international level and review basically what we could do here in Colombia, considering we have limited economic resources and even geographic resources. We have very interesting ICTs elements that we can use for the psychological intervention, as Dr. Castro mentioned before. So this is a program that has no history in Latin America. This is the first program in Latin America where we want to leave this record of the carer and how we approach the psychological elements. So through this program, we would like to develop the role of the caregivers, that they have a more appropriate approach in a more functional manner by the carer, trying to decrease the anxiety and anguish levels and other stressful conditions associated to this approach, and also reduce the potential impact both on the physical, mental, and psychological health of the caregiver. So this, in regards to the structure and design of the program that we are working and we are developing from the Promesa program, and we want to keep on going, keep on doing this in the future. Thank you very much for your attention. Claudia, thank you very much for your presentation. This is very important because we often focus on the care of the baby or the deceased child, and we sometimes forget about the caregivers or the carers because they have a difficult timetable or a difficult schedule. Following the program, we have the vision from the patient's standpoint. We have our guests, two people. We have Paula Cardenas and Hermon. Paula is a patient of ours, basically from a patient of Dr. Javier Castro. It's a girl with single ventricle pathology, also heterotaxia, and she has gone through all of this management. Currently, she was subject to Fontan surgery. We were even thinking about the transplant, but she has been very conscious in her medical management. So we will hear from her what is living with congenital heart disease like, the story from the standpoint of the protagonist. Paula, you are welcome. We are glad for your presence with us and to share your experience with the public in general. Please go ahead, Paula. Well, good afternoon, everyone. My name is Paula Camila Cardenas Alvarez, and I want to tell you about what it's like to live with a congenital heart disease. Good afternoon. My name is Milena Cardenas. I am Paula's mother. Paula was born on March 25th in the town of Charalá, Colombia, in a very unfounded hospital. When she was born, she was not diagnosed with her cardiopathy. She was born in 2002. When she was 1 year old, She had we thought she was all well. When she was in her first birthday, we noticed some health complications. She was not able to walk well. She was cyanotic. She had difficulty breathing. But she was cyanotic at birth that they said that was quite normal. There was a skin condition. So she was diagnosed by Dr. Quiroz in San Gil. She was diagnosed with a congenital heart disease. For us, that was a hard news. She was my first child, and everything, they told me everything was complicated. There were no treatments, choices in Colombia back then. So Dr. Quiroz, with the help of Fundación Cardiovascular, they took us to the USA, and in New York, in the Children's Hospital of New York, she was operated and she had her gland. We were there for a month. Medical care was excellent and people was very, very nice to us. So thank God everything went well. We came back to Colombia to continue with the treatment. They suggested us to live in a warmer climate. So she lived with me in Barranquilla on the Atlantic coast for 2 years. She recovered. We came back to Bucaramanga and we began the procedure or the follow-ups with the foundation. Now her life has been normal, but at age 8, it was necessary to have the second surgery, which was the fontan that was done here in Fundación Cardiovascular. Then we met Dr. Javier. He gave us, he was with us 100% all the time. But even though we live in a distant town, we come back to him, we come back to consults. However, when Paula was 9, she had a health complication and a transplant. And a transplant was required. So thank God there was there was a good medical option and good medical team and good medical management, but she didn't require a transplant. She has been living with this disease, and now she will tell us about the experience. So what has been living with this congenital disease? Actually, it hasn't been easy, but it's not impossible. With the help of my parents and the medical group, I have been able to manage the disease. I don't have many memories from child, but I remember I had difficult times when I was small. Why couldn't I run? Why couldn't I dance with my friends? And why did I have to go through all of these tests? So as I grew up, I understood more and more of the subject before being able to understand. To I am and I consider myself a normal teenager. I have normal interactions with people around me. So this has helped me to leave aside my insecurities, to grow as a person. My scar became something significant for me, something important. And I started living life. I started going out. I started studying, going to school. I tried to, I have tried to live a normal life. I even finished my high school. My advice for patients and their families that are listening to me uh, is to have faith, to, to, to have faith on the treatment and on your team and the treatment the medics provide. This helps you grow as a person. This helps you go through this disease. Also, the support and the love you receive from your relatives, that's also something important that helps you cope with this disease. Thank God we have the support and the dedication of the medical team that we come to the point of not feeling sick, of not feeling tied down to a device. So actually, I am very grateful with all the doctors I have met during my lifetime, and especially to Dr. Javier Castro. And I remember him very dearly from my childhood. So to all these boys and girls that are watching me going through this disease, well, I wouldn't call it a disease, but a way of living that shows us a different way to approach life or to live life. So you need to keep faith on what you can do or what you can be, and the importance of the relationships with your families, with your relatives. So all of these aspects help us have a more normal life. We also need to have a kind of a life plan. My life plan is being able to start to have a career in graphic design. I love painting. I want to explore that. I want to go to a good college, being able to fulfill my dreams, being able to raise a family, to become a professional, and continue growing as a person. And last, I would say that it is possible to live with half a heart. Thank you very much. Paula, thank you very much for your presentation. Very interesting. Thank you very much. Fight, you have given a fight on all your life. Our success is to see you having a life with very good quality and you are achieving your goals. Congratulations for that. Thank you. I want to ask Paula, I would like to ask you, how can we, how to improve, how can we look after better our patients or the parents? What would you recommend? What could we improve? Well, I wouldn't believe there are things to improve, but I feel you are doing things right. I feel well with all the support you have given us from the hospitals, from Fundación Cardiovascular. They have given us tremendous support. I, I, I remember a lot when I was after the surgery, nurses would come by. They kept looking after us. Always they were always aware of us. I don't have any complaints. I felt they really worried about us. What you're doing with Promesa is very important. Unfortunately, when we began the process with Paula, this project was not in place. But even though if Promesa was not there, as parents, we felt your support, the support of the medical team and the staff. So from the beginning, that has been very important. But now with this program and listening what you are offering, that's extremely good, both for the carers, the caregivers, and the patient. It's important to have this because sometimes we would feel that in uncertainty of is my child well, is he sick or not? But having this support, that's something that I would like to highlight in this moment. I get a question from the audience through YouTube. If Paula, if you can tell us about the complications any complications you had, or if you can talk about those complications that we have at the beginning when I met you. I would like to talk about it, but I have very little memories about that. But yeah, me as a mother, I remember a lot of that. At first, uh, when Dr. Quiroz told me your child has a severe cardiopathy, we need to move, we need to do something. And at that time, as a caregiver, it froze me there. I didn't react. Fortunately, I had my family support and medical support, and I was able to react. And back then in Colombia, there was no hospital capability to have those kind of surgeries. But we also had the opportunity of the great fortune of having this program Heart to Heart with Dr. Quiroz, and he took us to the surgery in the States. So to me, that was the most difficult time. Afterwards, well, perhaps some difficulties in the medications, but when the transition to being an adolescent, the medication becomes more difficult because sometimes, sorry, the now she is 18 years old. She has the consciousness that medications are important for her. Somebody is telling us in the chat that when the news is given of the cardiopathy, there is a sense of guilt on the parents. I don't know if you want to tell us, did you feel that you did something wrong? So the child was born with a cardiopathy? I don't know if you have something to contribute on that. Well, despite that, 18 years have elapsed, and I have no children. That's a feeling I still have. What did I do wrong? Why was my child born with that cardiopathy? So what did I do wrong? So that's something I have asked myself during 18 years. So so I don't have a response for that or an answer for that or what happened. What is important here is not the why, but how are we going to solve it? How are we going to move from this inconvenience, from this disease, up to a normal situation? But now we have more hospitals, more medics, and science has been going has had progress. Paula, what do you feel? How do you feel? What do you think about that? So we try to, or what this is about. I'm sorry, I'm losing the audio. I'm sorry, the original audio is broken. I'm not able to follow. Oh. So now that we have Paula Perez, the psychologist, what would be your opinions on what the patients? Well, guilt is one of the emotions that is most difficult to process, as our patient's mother says. And we see it a lot in our caregivers, despite the fact that the medical team explains very well that there is no reason or something they have done during their pregnancy or during their life that have caused the disease. I have observed them and I have accompanied them in the process where they are explained that this is a random thing. But as the mother just said, as time goes by, that feeling does not fade away easily. I believe something valuable is not to remain on this rumination, on this loop of why, but what do we do from now on? That is perhaps the healthier approach. And this is something that from psychology we want to make easy for the parents. I would simply want to add that emotions such as guilt are not solved in a unique time. These emotions may reappear along the child's life cycle, and that is why they may be worked on in a first time when the baby is small, but as the child grows up and is going through different life difficulties, that emotion may appear again. So it would be necessary to work again on it. So on mental health, both not only for the carers but for the patients or for us, is a whole pathway, is a process. So I need to identify where I can ask for more help to be able to move on, to go through life. Well, thank you very much for the questions. We have other questions on the with regards to medication. I would like to ask, after fountain surgery, how long? I know I'm not following. Pero cierre el micrófono. Well, the medications are actually all medications are important. Each management has been very specific for the condition the patient has. For cardiopathy, we have similar names, but they are different particularities. So we need to have a very close monitoring across the management of the needs of the patient, and that requires long-term follow-up. So it is important that people remember that congenital practices are pathologies that require lifetime monitoring. That's why they require a medical team with continuous monitoring of what it says, such as Paula. Paula was aware that she needed to adapt behavior for her success, but Milena Paula has been able to get empowered with her life project, with her life plan, and that's ultimately the goal. We need to get our patients to. So all of this program, we intend to have our patients in a situation such as Paula's, to have a person contributing to the society. So that makes all the social and economical investment is returned to everybody. So each management, each treatment is a specific. The best recommendation is that each treatment is adjusted to the child's condition. Some may require anticoagulation, sometimes transient or for long term. It all depends on the specific case. And this is something that will be changing, and it will require uh, follow-up from the professional working on the case. I have another question on the chat. How can we set up a program like this for follow-up of patients And I want to give an answer to that. This goes from the needs that we have with this sort of patients, not only as practitioners, but the parents. And in the Colombian context, this is a reality that we are trying to solve. Here, what is important is to do it, is to do what we are doing in the foundation with the support of the university. This has been done for 4 years, but it is actually possible to do it in Colombia. And this is something where we should go to. In that case, this program is allowed to take care of patients in any place in Colombia. And it's important to be replicated in any areas of the country or for other pathologies such as diabetes. This is something where we have an opportunity for improvement in all medical centers that are working on these patients. There was another question. In my country, insurance covers up to 18 years of age. What is the situation like in Colombia? Well, it depends on the context, social context for each patient. In patients such as Paula, fortunately, she managed to have independence, so she'll be able to get a job and generate the conditions to be to contribute to social security. But other children are not so fortunate, and they have a diverse degrees of dependence from their parents or their caregivers. So that has to do with the social or legal framework in the conditions in each country. There is an additional question: How can they how can healthy breathing be provided during the growing process for these children who have been so protected somehow and they require so many follow-up? So in your experience and Paula, from your knowledge as a psychologist, this is a question that parents ask a lot when they are discharged before the first interstage period. I had the opportunity of meeting some of the parents and explaining some of the things that happen to babies when they have not gone through a time in the ICU, because these children have some sort of rejection because they are not used to their home. So there is an adaptation process, and similarly, each intervention will require this adaptation process. So this is a sort of a mountain of a roller coaster with ups and downs and new gains. So in every change within the child's development process, an adaptation process is required, adjusted to the needs of the child and the family. That's why I said there was no perfect recipe on how to ensure that development is optimal. But what is important is not to lose sight of the fact that every time the child goes in or out a procedure or a treatment in the hospital or in the clinic, this adaptation process will be required again at home. So it is important that caregivers and parents acquire behavior flexibility strategies, as we psychologists say, and many caregivers have it to adapt to these demands on the hospital environment and the house environment, and they do that transition more easily. In our project, we saw a very big need of having a pediatric neurologist to direct one little branch of the program that would be addressed to those areas of neurodevelopment, such as language, socializing, motor skills development, because we noticed that with this return to the hospital, some of the gains that were obtained in development would be stagnant, or there were even some regressions. So the therapist In Colombia, they are provided by the HMO, but they will vary depending of the insurer. But we notice they are not sufficient. So within the coping strategies to these changes on the treatment, a very important one would be to get advice from healthcare personnel with experience in rehabilitation of those neurodevelopment functions that have been mitigated by the treatment. And it is normal because the child is not in an environment that allows easily to acquire those skills or to develop them. Uh, so on the affective level, it is important to take care of the emotional symptoms of the carers, as Claudia mentioned before, because this will facilitate that the child acquires social and emotional skills. There is one more question. Are these surgeries performed on newborns? Yes, several of the surgeries are performed in the neonatal term, both corrective and palliative. And within the palliative, there are several, including NORWOOD, the arterial pulmonary banding, the VT shunting, are frequently done on neonates. But when we talk about the stages, there are surgeries that belong to the time where the baby is in. For HLHS, the Norwood surgery is in the first week of life. Glenn surgery in single ventricle patients is around 6 months, between 5 and 6 months of age. And the Fontan surgery goes between the ages of 3 and 4 years of age. So each patient has a very particular anatomy, a very particular needs that make us decide one or other surgery at different times in life. And there is another question in YouTube for Javier. During these times of COVID, how have we done the monitoring on the patients? Sorry. Well, actually, Promesa is operating for 2 years, has been operating for 2 years. So we were already prepared for the pandemic. Telemedicine in the last 8 months have become significantly important in our country and in the entire world. But we have been working like that before. So actually the transition was not that strong. We were already used, we already had a system. And I'm going to answer a question in the chat. The geographical reach is global with ICTs. We may have this kind of monitoring from almost anywhere in the world. The issue would be to have a nice internet connection. Obviously, training and education is important, and even though we do it directly, and it allows to convey the information well, but we could do it also in a virtual setting, this sort of education. We have patients all around the country. We have patients in Nariño, in the south of Colombia, in the Atlantic coast, in some remote towns in Santander. The mothers come with a commitment to look after their children. They need to leave homes and go to a nearer hill where the cell phone signal is better, which is not rare for us in Colombia, particularly in rural communities, but it can be done. It is possible to be done. And it allows to have a communication, to have a clear and effective answer of what to do with the child, whether they need to rush to the ER or not, if they need to look after, because it happens a lot. They don't want to vaccinate their kids. And when they go to, they say they have a heart disease, they don't want to vaccinate them. They always ask for a letter from the cardiologist. And this allows to break this sort of a barriers and fears. Obviously, we need to take care. But these are some of the advantages that this sort of monitoring program provides for children with cardiopathies. And it allows to have proper care for complex pathologies. And patients who are not that complex in other countries, but they're actually complex for us due to social and economic conditions. I believe there is another question from Claudia. Yes, I see a question here on what are the key care that parents need to have with their babies. And well, in general, it depends on the pathology the baby has in the heart. But my advice for the parents for babies with heart diseases is to be really aware. Ask, because sometimes we physicians speak in an uncomprehensible language. We intend to do our best effort. We try to speak in the simpler language as possible so the parents understand what is the disease this baby has in the heart, actually. With what purpose? So that the parents understand what occurs in the disease, and when they go to another healthcare service, he empowers the management. He's empowered of the management, and he's the one that knows more. Because in general, heart diseases in children, even though they are common for us, because our hospital is devoted to that, but in the general population, this is not so common. So if you live away or if you go to a hospital in your area, perhaps the physician does not know what to do, or the nurse does not know well how to do. So my advice is, depending on the disease and the heart disease, there are some limits. One, or the saturation, or the oxygen level in blood, of weight gain on a day-to-day basis, or to say in 15 days they need to gain that much weight. So they need to give warning signs, and they need to be clear on whether there is difficulty to breathe, if they are cold all the time, if they become more cyanotic. So these things need to be managed by the parents with a clear goal of what the medic expects to have or not in these first months. Because let's remember, as Dr. Castro and as Dr. Chitra mentioned before, the first interstage period within one and another surgery is the most critical. That's when more morbidity and mortality occur. So the care depends on the heart disease, and they need to be very clear on the discharge for the parents. Well, thank you very much. This has been a very intense journey. We apologize for the technical difficulties. We are going through the transition with new technologies, but we hope this has been useful for all of you. The message is that this is an effort that we want to show and we want to share, and I believe this can be replicated elsewhere. We need to provide a better opportunity for children with congenital heart diseases. We have a very interesting day tomorrow. The first session is addressed to subspecialists, specialists in pediatric cardiology. We have guests from France and the USA, and also our colleagues working at the Fundación Cardiovascular and other specialized centers. So with nothing else to add, we want to thank you for the time and your presence. Even though there are some questions unanswered, we will continue solving your questions. And you can still write them on YouTube, on the YouTube channel. And again, my thanks to you. Remember, tomorrow there are two links. One where we have the original language for the presentation, and on the other link we have the simultaneous interpreting, depending on the language of the speaker. So without further to add, thank you very much, and we'll see you again tomorrow.